For the rest of my part of the presentation, I'm going to go over things a little quickly. I'm going to show you some slides in some instances for later reference, just to tell you what is there, but not discuss it very much. Because as I said before, everybody gets a PDF of the whole thing after the meeting, so you can refer to it later if you'd like. Okay, wait, I know we talked briefly. By the way, these are some challenging issues. It's not like there's a right answer to these ethical, legal, social issues. And as I said, there are some frameworks to use for these. I think some of them need further development. In any case, we've talked about evidence, but where do you get it? And how do you go about getting the evidence? This is actually an important issue because the sources of evidence matter. Where do you go? Do you just say, okay, we're only going to look at peer-reviewed published literature? And you might say that. You might say, we don't trust the rest. It might be biased. We're going to confine it to that. Or maybe English language. You know, some people say we can't translate all this stuff. English is the most common language in most of the world, if not all the world. Are you going to accept something in other languages? You know, if you're in Latin America, you want Spanish first, of course, plus English. But these are decisions you've got to make. Exclude certain countries. I know that in the US, when we look at RCTs of certain products, certain drugs, devices, biologics, sometimes we think, well, data from China may not be relevant, or India for this patient population. So sometimes you make choices about that. Gray literature, which is unpublished literature, if so, if not, how about data sets, registries, and ongoing trials? Do you include evidence from preliminary reports? What about conference abstracts? I usually would say no to those because I don't think they've been peer reviewed, but sometimes when you have almost no evidence, then you're looking for some early idea. Maybe it is relevant. So you have to answer these questions. Okay, then you can go to many places. Typically, mostly it's the journal literature, of course. But there are other kinds of information about the target population, the environment, the economy, other sorts of things. And especially in new areas, cutting edge areas, you might even go to some background information from a health newsletter or something like that, or the company reports. But mostly what we do is up here, starting to get more into some of these other databases. But again, you've got to decide ahead of time, what are our sources? Okay. Yes.
Good example.
Sure.
I think it's relevant there too.
Yeah.
Looking at things that are not directly related to the evidence and maybe like
Peripheral?
gray literature or stuff like that. So I like to sometimes look at the background of a drug, like how it was developed and things like that. So a drug X, for example, when I looked into its background and how it was developed, I found like there's a lot of patency, legal issues because it wasn't really considered or labeled as a drug, and they were unable to patent it as an innovative thing because it was actually a dietary component.
Oh.
So sometimes it's not what's obvious, but if you look at the trial and everything looks good and it's registered as a drug, but then you look into that background and you're like, there's something more behind it. And
Yeah, it's smart to do that. Yeah, ask below the surface, you know? Ah, good point. So some of these other sources may be helpful along the way. Good point, good point. When you do look at what HTA does typically, the most commonly used sources are PubMed, which includes Medline, Embase, Ovid, Web of Science sometimes, Cochrane Library. I'm sure most of you know about the Cochrane Library, especially their systematic reviews. Cochrane systematic reviews, which some of which have meta-analyses, are usually very good methodologically, very strong, because the Cochrane collaboration, I think they have more than 50 collaborative working groups around the world, and their standards are usually pretty high. So their systematic reviews are good. Not all of them have got into the published literature just yet, but I still think it's a trusted source. There are other sources. This is the Cost Effectiveness Analysis Registry, which is very interesting because it provides cost per quality in a register. It can be it's rather revealing. In any case, these are the most common sources. Okay, now, this is another subject we could spend a week on this, But this is an important distinction. Sometimes people overlook this. When you're looking at the quality of evidence or rating the quality of evidence, we do it at 2 levels at least. If I'm going to pull together all the studies and even do a systematic review on something, and I pull together, I don't know, 20 studies, I look at first the quality of the individual studies. How good is this RCT? How good is this observational study? Do they have biases and so forth? But that's not enough. Then you say, what's the quality of the body of evidence? You can rate that as well. Sometimes people forget, they don't know the difference. 2 levels, okay? Individual studies and the body of evidence, okay? And you can use, there are various instruments and grading tools and all sorts of things to do this. For individual studies, there are various instruments to assess the quality that they've got, and there are different instruments or tools for assessing the quality of different studies. Quality of systematic reviews, there are rating systems for that, RCTs, observational studies, even different types of interventions. Quality of screening studies, diagnosis, treatment, so forth. Some of these are here's some of the more widely used rating instruments, but here's some examples, okay? Cochrane, and I like sort of the visual here, Cochrane Risk of Bias Tool. These are individual studies for a systematic review. Best 2007, Bossy 2004, blah, 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 blah. These are individual studies, but for each one, they ask questions about potential sources of bias that would weaken the quality of the studies. Was there random sequence generation? Was the allocation to groups concealed? Was blinding, if it's possible, was blinding done of the participants and the personnel? What about blinding of the outcome assessment? When you kind of looked at the results, you blinded as to, was this a result for group A or group B? Just what were the results? We'll tell you later which was A or B, okay? Were the data incomplete on outcomes? You know, sometimes a study, when it's announced, says, we're going to address the following 5 outcomes. And this is the outcomes in our protocol. Then later on, when the study is published, they have outcomes for 3. What happened to the other 2? So maybe incomplete assessment of outcomes. Interesting. Selective reporting, other biases. So the point here is that each one of these studies was rated for 7 types of bias. So that's part of a way to rate individual studies. Okay, rating individual studies. Now, you get pretty complicated here, and I don't expect you to read this, at least not now. Later on you can if you want. But these are, again, looking at risk of bias for individual studies. Here of different types. Here's how you do bias for RCTs, for controlled clinical trials or cohort studies, for case control studies, case series, cross-sectional. The point is that even depending on the type of study, RCT or something else, you have ways to rate biases and other aspects of a study that would weaken it. Individual study, this is the individual study level. So everybody see that, and a lot of tools to do it. Then you say, oh, how do I do this in a reliable way? Look at all these. For just RCTs alone, there are various quality rating tools or checklists. I think the earliest one was the Jadad scale. This is 25, 30 years ago. But these are others that are used as well. So there's about 7, 2, 4, 6. There are 8 examples here of how you would rate a study or do a checklist. Now, as I mentioned earlier, you can use these in 2 ways. One way is, here are the 10 RCTs, here's how to rate the quality of each one. And that was what HTA would do, like using a checklist. But if you're designing an RCT, let's say you're a pharma bio device company and you're planning a randomized controlled trial, you'd say, well, how do we look at the quality of the trial? Later on, they're going to be looking at it using a checklist. We better make sure that our trial is valid as well. So they can be used for both reasons. Now, let's switch to the body of evidence. Let's say I pulled together 10 RCTs and maybe some other studies for systematic review. Let's call it 10. Let's say that of those 10 studies, let's say they're all highly rated. They're all individually good studies. When I put them together, these studies are in favor of technology A, some are in favor of technology B, Some are equivocal, they're pointing in different directions, they've got different sample size. Even though each study has high quality, the body of evidence may be equivocal or difficult to handle. So, systematic reviews assemble bodies of evidence, that is, groups of studies. Each body of evidence may comprise studies of one design. For example, RCTs are a mix of study designs. And there are many approaches to assess the quality of the body of evidence. And here's some, many of you have probably heard of GRADE. I used GRADE when I ran a clinical practice guidelines program for years. We used GRADE. Cochrane Collaboration has ways. These are all groups that have nicely established ways of rating the body of evidence. Now, again, stick with me. I'll try to do this briefly. GRADE does something very good with the body of evidence. They start out with something that, this is almost like an evidence hierarchy, right? You've got, but a group. So we've got mostly RCTs and then some observational studies. So stronger evidence here, weaker evidence here. But they don't stop. They say, well, yes, we have randomized trials, and initially we'd say, oh, we got a lot of RCTs, we have high confidence. Oh, we have too many observational studies, we've got low confidence. GRADE does not stop there. GRADE says, wait a minute, there are some aspects of the groups of studies that may increase your confidence or decrease your confidence. For example, if when I look at the group of 10 studies, as a group, they're biased in a certain way, in one direction for various reasons, or they're inconsistent at some point, group favor technology A, some favor technology B, or the evidence is indirect, not enough head-to-head studies. The studies themselves are good, but as a group, there's too much indirect evidence. Imprecision, publication bias, all of these factors would push down your confidence in your body of evidence. On the other hand, there's some things that may push up your body, your quality of the body of evidence. For example, if overall there's a large effect size, wow, they're pointing in the same direction, there's a large effect size, I might have greater confidence. Or maybe there's a dose-response effect. Across the 10 studies in general, when you increase the dose, you increase an outcome, one way or the other. In any case, this might push up some of the observational studies. So where do you land? Where do you end up? And you might have seen this. One of your readings was the GRADE handbook. There's a lot of detail in this. You end up, you start here with your studies as a group, go through this process, and in the end, I have high confidence in the estimate of an effect, okay? High confidence, moderate, low, very low confidence for the body of studies. That's what GRADE does. That's something I really like about GRADE. But the point is, it's one nicely established method for evaluating the quality of a body of evidence. Remember, individual study, quality, body of evidence study, quality. Okay. Another step that you might see is, for a body of evidence, is developing a finding or recommendation based on that. And I'm going to show you a very good example. I know this looks complicated, but follow me here, okay? My body of evidence, we're going to look first at this component, comparative net health benefit. The body of evidence says I have no benefit, a little benefit, like comparable benefit between A and B, or a small net benefit or substantial benefit. This measures the effect size. Little effect size or even negative, moderate or large. This is the size of the treatment effect. Not the quality yet, the size of the treatment effect. On the other axis, you have the certainty in the evidence. How strong was the evidence? Remember, high, moderate, remember this? Hold on. Remember this? High, moderate, low, very low, something like that. This is how strong the evidence was, the quality of the evidence. This isn't about the quality. This is about how big the treatment effect is. This is not about the treatment effect. It's how strong and high quality the evidence is. So, when you have an instance of, let's say you have a substantial net benefit, big effect size, and high certainty, high quality of evidence, they give it an A rating. Superior, high certainty of substantial, moderate, large net health benefit. That's A. On the other end, let's say, oh, I have very strong evidence, but it's for a negative treatment effect. That's called a D. D is negative high certainty. I'm sure that there's a negative benefit. So the evidence is really good for negative. So the point is, this is a way of displaying for a body of evidence, not a single study, a body of evidence, two important dimensions. How big is the treatment effect? How confident are you with the quality of evidence? And with that, you can say, my recommendation is an A-level recommendation, or my recommendation is a B plus or a D or insufficient. Insufficient says, I don't care how big your treatment effect is, the certainty's low. So I'm not going to do anything with that. Okay. Now, if you care about the quality of research used in health technology assessment, there are all kinds of guidelines or tools that would help you assess a body of evidence, okay? In various different ways. So assess individual studies as well as the body of evidence in some cases. For example, CONSORT is Standards for Reporting Clinical Trials, usually RCTs. MOOSE, I like the name, Meta-Analysis of Observational Studies in Epidemiology. Quorum is the quality of reporting of meta-analyses. So if you're trying to assess various kinds of studies, RCT, observational studies, meta-analysis, whatever, there are tools or checklists that help you be objective about rating the quality. Yes?
I just want to add one thing. Now, the journals, when you do any trial, they ask you which quality reporting that you use, and you have to report this within the journal. So most of it, QA, they require word that you follow.
Good. That, yeah.
Now they mandated that.
Excellent, excellent. But there's so many of these, you know, Robbins I, risk of bias, and non-randomized studies of intervention. So Strobe is observational. You get the idea. There's many checklists that you might draw upon. Okay, quickly, horizon scanning. What are you going to assess next? You've got a certain budget, a certain amount of time, and so many things are coming your way. Horizon scanning is a way to say, let's look over what's coming next. What do we need to think about or prepare for? What could be coming a year, 2 years from now? Looking over the horizon for something new. And also sometimes horizon scanning refers to actually doing like a mini early assessment. Based on the little you know, what are we going to expect? So you'll hear the phrase in HTA, horizon scanning. It can be used for a lot of things. As I just said, identify technologies that have potentially major implications, or can help you get ready for data collection to plan to monitor. All kinds of uses for horizon scanning, and there are programs that do horizon scanning. Okay, CADF has something, or now CDA has something really good. UK has a couple of these. I think they overlap. There's something called the International Health Tech Scan by something that we call Euroscan. So there are various organizations that do horizon scanning. You could do it yourself, of course, or you could maybe rely on them for some input. Now, back to how do you make decisions about what to assess? What tells you what you're going to assess next or in the coming year or two? Well, you might think about any or all of these criteria. These might be ways you might decide what to assess. Is there a new emerging technology approaching regulatory approval? Or high individual burden of morbidity and mortality, large number of patients, high individual population cost, high unit cost or aggregate cost, variations in practice, a lot of disparities in patient access, unexpected adverse event reports. Are your findings going to make any difference? Is there enough research out there to even conduct an assessment? So the idea is you don't need all of these perhaps, but when you are deciding how you go about making decisions about what priorities to set, this is a potential list of criteria. Chances are you're not going to use all of them, but these would probably be most of the kinds of criteria you'd want to use, priority setting criteria. Okay, I mentioned quickly something called early HTA. This is a phrase coming up more and more. Conducted during the developmental stage, like for drugs, maybe during phase 1 or 2 clinical trials. Trying to get an early fix on what this may look like. minimize risk and uncertainties, estimate potential value. Pharma companies and device companies use this thinking about go, no-go decisions. In other words, okay, we just finished phase 1 trial or maybe even phase 2 trials. Does it look like we've got something here? Yes or no? We're looking at initial kind of treatment effects in phase 2 trials. That's not definitive, but is it pointing in the direction we like? Or in the meantime, has our competitor gone way ahead of us, and so we shouldn't even bother to do it? So this kind of early HTA, even by technology companies, would inform go, no go, and you could use various methods to do early HTA. There's some very good recent papers out about what early HTA is. When do you assess? Interesting. Timing. No single correct time to conduct an HTA. It depends on what evidence is available. It depends on what your job is, your mandate. It depends on whether you need to wait for regulatory approval or not. But the point here is that there's no single right time. It's conducted to meet the needs of various policymakers and decision makers. There are trade-offs. You assess really early, maybe you don't have enough data on long-term follow-up. You assess too late, it's out there, it's being used, and people are experiencing adverse effects that you should have kind of thought about earlier. So this is what I call the moving target problem. Things are changing, the technology changes, the comparators are changing, data collection is changing, patient populations are changing, which the technology is used, so it's really a moving target. Okay, now, what makes you say we want to revisit a technology? Not maybe the first time, but later on. When would you want to do that? Well, maybe there's new evidence. New published RCTs just came out that the findings look a lot different than what you had before. Or learning curve, experience. Think about surgical procedures. At first, the surgeons aren't very adept or good at this, or after a while, they learn how to do it better, okay? So there's a learning curve associated with this. We came across this years ago in heart transplantation. They improved their surgical technique. Or now with gene therapy, how and where you do all the very complicated steps in gene therapy, there could be a learning curve there. New indications, GLP-1 agonists, right? For diabetes, but now for heart disease, but now for substance use disorder, now for something else. We have to revisit the technology because it's being used differently. And new context, it started inpatient, now it's outpatient. Oh, it started outpatient, now it's in the doctor's office. Oh, it was in the doctor's office, now we're doing it at home. So we're doing different places, and so forth. So these are all ways that you'd say, aha, ding, time to reassess. Okay, I've already talked about some of these already, and I'm not going to go over these in detail, but just briefly, take a quick look at NICE in the UK, CDA Canada, HOST France, ICWIG Germany, ICER US. And I just put together one slide in each of these. I think among the important things here are, what is the mandate here? What is their job? How close is the assessment to a decision or a policy? In the case of NICE, it does function as a national HTA body for England. It is legally obliged, the National Health Service is legally obliged to fund and resource technologies recommended by NICE technology appraisals. NICE does a lot, by the way. They generate evidence-based guidelines, they do a lot of things. What we call technology assessment, they tend to call technology appraisals. They have special ways of doing devices and diagnostics. They've got the HST, the highly specialized technologies assessment for rare conditions, and so on and so forth. I would say that globally, the most comprehensive developed HTA program is probably NICE. I would say they're also very good in patient engagement and industry engagement. I remember when they started, it was 1999. Remember that? And the first thing they did was a therapy for flu. There were some early missteps, but they worked very hard at adapting their process. They're tough. They're very tough. And a lot of people don't like their cost per quality threshold, but I will say this. They're transparent, and they do make modifications over time. Maybe not as fast as some would wish, but they do. Okay, Canada's CDA used to be called CADIF. It's independent, not-for-profit for the country's publicly funded health systems. It has various evidence product, it does horizon scans, it does health technology reviews, which are kind of most of what we've been talking about today, but also looks in particular at reimbursement reviews. It also provides scientific advice. Oh, don't forget this scientific advice thing. NICE does this too. In general, not everyone, most advanced national HTA programs have opportunities or portals for industry engagement. That doesn't mean that industry says what we're going to do, but it does say, all right, early on, let's talk about evidence expectations. Let's talk about what we're seeing initially. Here's our draft report. We're going to share with patients too. So the various opportunities for industry engagement. And so the scientific advice, in this case for pharmaceutical companies, on early drug development plans from an HTA perspective. This is better than not talking. This says, look, we know you're developing something in, I don't know, phase 1 trials. Let's sit down and talk about it now. What are your plans to generate evidence? From our standpoint, HTA, here are the kinds of things we would like to see. Let's talk about what endpoints you're going to use. Can we talk about your trial? HTA can't tell you what to do, but it's good to have the conversation. By the way, it's bi-directional education. The HTA programs can learn a lot when they talk to the pharma and bio companies, and vice versa. Works both ways. But the early advice is a good thing. We're seeing more of it. HAS in France is a non-governmental public scientific body, but it does have particular missions here about pharmaceuticals, devices, and procedures, in particular for inclusion on their national reimbursement lists. It also recommends best practices, has worked with vaccinations and so forth. Here are the main HTA processes: medicinal products and devices, HTA performed at the request of the manufacturer. It does others at others' request and so forth. So HAS has a certain set of responsibilities that kind of lay out the scope of what it does. IQWiG in Germany has a very tight relationship with the GBA, which is their federal joint committee, the GBA, and they're functionally independent. But when GBA asks them to carry out certain responsibilities, GBA's responsibilities, they get advice and support. GBA gets advice and support from IQWiG. It generates evidence-based reports on these kinds of technologies, drugs, non-drugs, diagnostics, clinical practice guidelines. And when pharma companies submit a dossier, okay, drug dossier assessments are conducted in the framework for early benefit assessment. And at market entry, manufacturers submit an evidence dossier to show that their drugs provide added benefit versus current therapy. But GBA can then say, okay, take that dossier, IQWiG, and tell us what you see there. And then we might adjust. There's a lot going on with adjusting the price. Industry comes in, here's our drug, it's approved. This is our cost, but later on, the cost can be revised downward based upon an IQWiG assessment and other early experience. Yes?
This is one of the things that is a good example for your question. You were asking what to consider the value assessment or what's the value attribute. Actually, they call it GABA because the way they pronounce it.
Oh, the Germans? Yeah, I see a GBA.
So they actually insist to have additional added benefit, as you just mentioned. So if you have an IV, the same drug, in oral, they don't consider it for addition because it doesn't cause an additional added benefit and health. So they just agreed and decided. They call it in the beginning efficiency frontier, but then later they changed. But anyway, they decided the only drugs with added clinical benefits to be reimbursed, which is not really important.
But you can still get a lot, if you have a large clinical benefit, you can get paid more. Yeah. But if not, right. Anyway, very controversial in Germany. They're tough. They're tough, I'll tell you. Yeah, oh yeah. The last one is ICER in the United States. By the way, if you kind of get how clever this is, my friend Steve Pearson founded ICER 20 years ago. And he calls it they call it the Institute for Clinical and Economic Review, ICER. But we already know ICER is also incremental cost effectiveness. He was very clever how he did that. Very, very clever. Now, what's different here, ICER has no legal authority to make any decision for anybody. They just do these assessments. By the way, their assessments look a lot like NICE assessments, very similar. And their money doesn't come from, the money comes from nonprofit foundations and others. industry money cannot go to support their assessments, but industry money that they get goes to support a forum and other non-report activities, like various meetings and discussions, not assessments. So they're very careful about that. ICER does have a suggested cost per quality adjusted life here between $100,000 and $150,000 per quality. And then based on that, they say, well, if you want to stay within $150,000 per quality, we suggest that your price ought to be something to bring it to that. And often the price is below what the industry wants. But again, nobody's obliged to use it. In some cases, ICER's suggested price is actually higher than what industry thought, which is interesting. So, but the reason I'm showing you this is that in opposition to NICE, which has a very specific legal mandate about how their assessments are used by the National Health Service, ICER has no such mandate. But many organizations use their assessments anyway. Okay. AI stuff. Quickly. Here are all the ways that AI can be used. Someday maybe we'll talk about this in greater detail, but and this is just emerging, but AI can be incorporated in look at all these steps. We've talked about every one of these things. AI can have a certain kind of role, probably early on, mostly kind of supporting, kind of doing a lot of the work for systematic reviews. Maybe a little health economic model, that's very sophisticated, but it's going to have a greater role. Wow. AI, excuse me. These are ways in which AI could challenge HTA, make it harder. Well, for example, if you use AI to develop drugs in silico, as we say, and you generate a lot of new drugs, that's more than they've got to do. Personalized drugs, you can use computerized platforms to develop a drug for you that's different than a drug for you that's different than a drug for me. Personalized. How do you assess that every time? Well, you probably have to assess the platform that's used to make those. Anyway, it's a very complicated question. AI screening and diagnosis. AI is used for reading mammograms, for example, and other kinds of aspects. Medical devices that use machine learning. If the regulatory agency approves this device, and this device uses machine learning, it has an algorithm, but the device also uses machine learning to adapt the algorithm over time based on more input. Is it the same device? No. It switches the algorithm. So do you have to come back and, how do we deal with that? Interesting. Okay. If you care about drugs, because you're formulary people for the most part, or you develop these, along the whole continuum of drug development, like what are the possible target molecules, targets, what molecules will be the key to unlock the target, clinical trials, manufacturing, everything. If you look at the whole range of drug development, all the way from identifying potential new disease targets, through designing new drug molecules, compound discovery, doing the clinical trials, recruiting for the trials, patient adherence, even post-marketing surveillance, AI can have a role in maybe most or all these at some point. Not yet for all these, but eventually it's going to have a greater role. And by the way, if you're worried about AI, here are reasons to be worried about AI. So there's a lot of upside to AI, but there are ways we've got to be very careful about how we use it. There are a lot of ways that algorithms can be biased, a lot of ways. Most of you probably know what an AI hallucination is. When AI makes up the answer, which it often does, risk to privacy, security, and so forth. By the way, if you care about guidelines or tools for assessing AI, we have those too. Look at all these. Here's Cheers that has an artificial intelligence add-on to it. Isn't that kind of interesting? Consort has an AI add-on. Probast has an AI add-on. These are tools that most of which already exist, but they've now adapted them or added on a piece or a module that is good for AI too. It's kind of interesting. This is a set of technologies that may pose really tough challenges for you. Really tough challenges. These, now I know you do oncology, but some of you kind of more broadly, how are you going to cope with the cost of all these things? It's enough to give them to people with type 2 diabetes. But if people come in for obesity and heart failure or heart disease, substance use, mental health, other kinds of disorders, you're going to be paying a lot of money for these things, and that's a very difficult one. Gene therapies, messenger RNA vaccine platforms, ctDNA, circulating tumor DNA, where they take a blood biopsy and see if there are little pieces of protein that are broken off from tumors. Sounds kind of interesting, but you're going to get a lot of false positives if you use it as a screening tool. Big problem. And then we get into wearables and all these sorts of things. So coming challenges to HTA from AI. Last couple slides. If you said, what are the overall trends in HTA? Greater demand for HTA to inform wide variety of decision making. There are more HTA agencies now, by the way, increase in number and their quality. More international collaborations in HTA. Wider adoption of good practices. We're learning how to do HTA better. And better horizon scanning and priority setting. More use of real world evidence. Looking at the wider impacts. Yes, tell me about organizational impacts, workforce impacts, environmental impacts. A lot of emphasis, as I said, on patient-oriented reported outcomes and patient-centered outcomes. More specificity in findings, heterogeneity treatment effects, patient diversity, how we look at subgroups of patients, value frameworks to describe how we do HTA, how we do methods and systematic reviews, including AI-enabled systematic reviews and meta-analyses and so forth. A greater emphasis on improving and standardizing economic analyses. We're always evolving these. Adapting these methods and standards for particular cases. We've learned how to adapt HTA to rare diseases, to digital health, the entry of artificial intelligence, HTA for telehealth, how we respond to pandemics, rapid assessments, as we said, coordinating and aligning with regulation and payment. Remember, getting these to talk to each other. And that advances in alternatives to RCTs. There are all these propensity score matching, target trial emulation, synthetic data, AI applications, and so forth. So it's not only about RCTs, we're changing even how we do RCTs and how we complement RCTs. And then greater opportunities for pre-assessment consultations like the scientific advice thing I just mentioned to you a few minutes ago. So if you want some trends in HTA, here's 17 of them. Okay. I'm sorry I had to move so quickly in the latter part, but it was for a good reason. We had so many good questions before. Someone asked for my email before. There it is, right there. But I will talk with you, Dr. Leolette, on getting a PDF to everybody. So I'll be quiet now, but I thank you for your attention. I see no one fell asleep. That's good. So thank you very much. We'll work through more. Thank you.
Okay, so we have the trial on every table. So I think we can fit into 4 tables or 5. So maybe, Dr. Hind, you want to stay here? Dr. Fatma, you want to move to maybe this table? And Dr. Cliff, you can stay on that table. Okay. You can stay where you are, Muhammad Ahmed, and Dr. Amal, and I'll move to that table. So if every table, you can start reading the trial from New England Journal on this medication for Alzheimer's, and then have like an open discussion in your group and assign one of you to write down the limitations of this evidence. So by reading this study, what do you think are the limitations in interpreting the value of this drug? And also list, let's say, what other factors would you need beside this evidence to decide on whether to reimburse this drug or add it to the formulary, or what more information would you want to see? So for example, we already had that discussion on this table that we'd need to probably know the price of the drug. So think of all the other factors that you want to include. So I think Dr. Cliff mentioned a lot today of other factors that influence HTA decision making. And then I don't want to say decide, but kind of have at least a notion, like what would you do next? Like, or what's your plan if you were to decide you have all these limitations? What would your next step be? Would you demand something extra? What would that be? So 3 things. So what are the limitations? What other factors would you want to see in order to decide? And the last thing is, what would you want to do? Decide immediately or think about other stuff? Is that clear? Okay, so you have the study there. I'm gonna move to that table. مين معاكم انتو؟ لا معاكم حدا. دكتورة أمل أنت هون. محمد أحمد. Okay, let's. Is that yeah? You can move to Dr. Amal's desk, and I'll move here.
The study is a randomized, multi-center, double-blind, phase 3 trial where they use placebo on one arm and the other. They followed the patients for up to 18 months, and the outcome was improvement on a scale called CDR-SB. CDR-SB. The CDR-SB, it's a tool. It's a tool that looks at multiple things. So it's a score from 18 that looks at the function, memory, multiple the more that you score, the worse you are. So anyone who has a CDR-SB score, let's see the difference over who would take those in the placebo when they started, that was and then from 18 months, it was 1.2 lengthenamab, and it was 1.6
This is regardless which the score is for all
the baseline was so if we look at the baseline characteristics, other than so this is the mean score, so there's still worsening arm, but not as much so see, they start to reduction, how much they reduce, like I said, Tom 18. So how much they reduce? 1.3. Yeah. No, how much is
the higher the score,
yeah, so the placebo arm had almost 1.66 reduction. So if you read from the abstract, it says the adjusted lesiogram mean change from baseline at 18 months was 1.2 with lecanemab and 1.6 with placebo. Yeah, the reduction was less with the reduction. So how much the
comparison between
placebo. Okay. So the main difference is minus 0.45. The clinical dementia rating there are some boxes. From baseline at the age of 6, your main primary. This score is a validated measure using clinical trials from Alzheimer's disease that is affected by interpretations and the care participants and taxes cognition and time to following rules. You follow up on that. Yeah, but it's a question here. They ask which score that was their responsibility. So we need to think about what are the limitations of this type of trial. So it says that it assesses 6 to 8 patients and the caregiver with a higher score indicating greater improvement. So the higher the score, the worse you are. يعني it's 18 you can get 18, okay? It's multiple things, okay? Cognition, hobbies, and how you take care of your personal care, okay? Everyone is from 0 to 3, right? From 0 to 3, this is from 0 to 3, okay? The higher the score, the worse you are. Okay. So, the difference when they did this, they followed up the patients from baseline to 18 months, they had 1 point in placebo was 1.2, and the 1.6 in the placebo has increased to 1.6. صح؟ وهذه 1.2
1.2 for
it increased, yes. Yeah. فهذه case the scale, the higher is worse, and so they didn't. The difference was a bit less with treatment.
the effect of clinical reversible or irreversible?
That's a good question. Let's put that down. So other factors, long term, efficacy, continuation, let's say. After 18 months, right? So that's important. You want to know, do I every 18 months. So let's say it's a chronic disease, we want to know. So that's an important factor.
For every above 80.
Still has a job, still has a family, accidental, let's say, versus someone who's maybe 80 and has cancer. Quality of life and not. So the drug is taken as an influence. I think that's also like burden on patients every 2 weeks. So included were physical 50 to 90. So we list that as a limitation, maybe the value of the drug is worth it, or might well, they have multiple secondary so they also looked at the CT scans, elimination, let's look at we can list that as that a limitation that they excluded many patients with comorbidities, so we don't know what the net benefit is. Yeah. Yeah, so we can go to higher eligibility criteria. So
So maybe as well, this is versus placebo. We don't have
So this is very important. So standard of care for Alzheimer's is usually Memantine and cyclin esterase inhibitors, which are not considered disease modifying. So they have some of the symptoms, but they don't change the name, like the prognosis of the disease. So this is one of the first groups that are considered disease modifying and prevent continuous decline in cognition and everything else. So is it fair to be a placebo? That's what the drug regulators ask. But you can also argue that we don't know if it's better than just doing the standard of care, right? So one thing is to look at what did they actually do to the both baseline and placebo. So they continued their medications, which is standard of care of the comparator. I would say sometimes we don't have any other disease modifying agents in the monitoring. Yeah, the other combinations, other drugs administered, baseline, you'll see other drugs announced, I think it's I want to do the control
they achieve the progress, then they go to the second.
The presence or absence of medication for symptoms of Alzheimer's and things that based on example estimates temperatures, memantine, those were not selected and just because they were allowed to.
Well, it's not a perfect predictor.
So one thing to think about, we have different background medications also that might be beneficial is to always look at the baseline characteristics. It has to be equal between the placebo and the baseline levels. You have to start with two groups that have no other same age, same like risk factors, and then now you whatever change that happens after you use your intervention to say because you that's more constant.
Diabetic patient.
So the mean age is 70. It's right, but you do have this early onset Alzheimer's. So their inclusion was anyway. But that's a good pattern. You should look at standard deviation. So it's 8. So yeah, maybe the youngest was probably 60s.
Double blind.
To evaluate potential effects of functional underlying due to area effects. Often dose is due to this, it was sent. You didn't get it? I mean, it's an interesting thing to think about. It's actually targets it's a humanized IgG antibody that binds to high affinity to alpha
base
So in this case, it's reasonable.
So even one of the secondary outcomes, they can assess the CT scan
What
patient.
is mainly sensitive and specific to reach the certain receptor of the brain for treatment of the Alzheimer's disease other than the traditional formulation of drugs. But
Yeah,
We don't need the same.
exactly. So what's continue? Yeah, so that could be maybe a factor we want to know. It's like, is this going to be like a cure, or is it something about measurement of benefits? Do you think that's problematic? That you ask them, you have to ask you them, you have to ask them.
And they give us the
How many times do you forget your keys? Are you having trouble taking care of yourself? Do you think that's wrong?
kind of rationale depends
Yeah, so do you think sometimes it happens to you, don't they introduce some
So that seems like quite an
So there's types
intensive
of bias that like we call them. So like that, if someone already has a mental problem and you ask them something like that, it's a problem, right? So it's not really, let's say, very objective, even if it's a number. Okay, it's a number. So 18 is a score, but it's not objective because how you're collecting the data is subjective, right? You're asking patients or their caregivers, tell us about this patient, how this doctor is all of these are questions that we depend on a lot of other things. Sometimes it's variable from even a healthy person, right? Like stress, when you're stressed out, you're under stress, or you have other diseases, you might forget.
This is it.
I'll put that down as a limitation if you'll agree. Yeah, it's the moment. Yes, of course. Of course.
So that it is psychological if you are taking that's why but when you feel you are taking
Yes,
you feel good.
exactly. So
And these people they are acting as a psychological
you're
problems.
right.
As when such kind of the condition studies are conducted, those people who are even when you feel in psychology you are taking this
Yeah.
even drinking simple water
So
injected
yeah. Of course, yeah. So blinding, we say that blinding is important to deal with subjective things that you might think the patient might feel better just because he knows he's on it. So one of the things to think is sometimes blinding, even if it's done, it's not effective because maybe there's subtle side effects that are making it clear that it is the drug you're
أو إنه negative evaluation is very limited and we can't provide understanding evidence or whatever. That's why
blinding might be
automatically negative study يعني negative تلاقي
I feel better.
زي
I
المجرد
suddenly remember more.
مثلا عندنا دراسة عن التاكسيز ومدري ايش زي مساعد هذه يا بنات
Other drugs can say efficacy, how they account.
They mention anything other than
Hospitalization. but they did look at multiple other secondary outcomes like the actual CT scan for thrombo. It's exactly the same, but with the drug, it's actually got much better. Yeah. So this is what they saw in healthcare. So this is objective actually. So this is one of the objective measures. So they looked with the X-ray, they actually saw these things disappear in the treatment. But how is that translated into actual benefit? So this is what when Dr. Cliff was talking about surrogate measures or biomarkers, this is maybe a biomarker. This is more of yeah, you can so yeah, these are the ones. This is another scoring tool. So different. They use different scoring tools. You want to take a seat?
انا بس بسمع والله لانه ما جاتني
It's okay. So actually, if you look at the biomarker, like the PET scan, it looks very good. So they have a the black population is underrepresented. But do you think that's an important factor, like looking at genetics? Doesn't Alzheimer also a disease that's much affected by the environment? Somebody who actually is scientifically active, reads a lot, actually works, is different than a person that's not really mentally active. Right? So you're looking at that as one of the factors to consider the effect of the environment with disease. Do you think that might have an effect? So genetic and environmental background.
Immunity, autoimmune disease, maybe related to our disease, autoantibodies, self-reaction by
whatever the patient has lost.
They usually have no response. So this shows how many continued until the end. So at each point, how many were lost. So if you look at 18 months, you have 7.7 million. That's a good false.
Falls could be a factor. Is this reduce any of those things? A lot of money to pay.
So that's unequal.
The nature of the disease itself.
This is what we want to be able to analyze. You have too many drugs. So that's something to think about. But in this trial, it's actually good. So at the end, almost 700 is equal to.
Did I mention the reason of drop-off?
Yes, so you heard Dr. Cliff talk about the concert. So every trial has this kind of diagram. They have to detail every patient why they left out. So they look at their, for example, this discontinued trial for adverse events. 3% in the
the limitation.
2.9. So it's very good. So this type of like diagram, it's like a must in well-established journals. They ask for this to show exactly where everybody left.
the percentage for abnormality is in Europe more than the European countries. What is the reason?
I'm not an expert in neurologist, but I think there's a lot of detection and diagnosis. So that's one of the factors that is brought up with this disease, detecting Alzheimer's at early stages. Because if you look at who they included in this trial, are those patients that were mild to almost moderate. So their score is less than 6. So it's 3. That's very, very mild. So maybe in our society, we don't say, okay, we're like that, but to actually get the diagnosis and have a neurologist see the probably already have severe so sometimes delay of diagnosis
long term.
So sometimes it's just it's part of the so I'm going to put that as another factor. So
maybe you might find
it's for this medication to actually you have to have early diagnosis, right? Because we don't have those abilities everywhere in our let's say primary
so long term both
Maybe social factors, cultures,
and
here we contact with
effectiveness.
our Europe
we said that environmental things,
isolation.
isolation, like
Contact with the person, no action.
environment, yeah. So your environment.
غير مسلمين.
No, the limitations. The limitations we have the outcomes. We have
معناته كل ما قال كل ما جمعت الانسان يثبت انه البيشنت عنده الزهايمر كل ما كانت المحافظه على كل ما كان عنده الزهايمر اكثر فمع انه الديزيز فهو مع الميديكيشن
So shall I say maybe that's the disease variety? Let's say variety.
this comes to safety.
So shall I say that one of the limitations or other factors we want to know is the subgroups, like how Alzheimer's is a disease with wide
which can be 99.99% specific and sensitive. No one up to know. Because I remember that since 1997, I'm listening that they have developed some of the drugs many people fight the one I'm looking
that this difference that you're seeing is not like there is actually, but it doesn't tell you how big
as a family history. They should never get this if they are going to but it is
after 18 months of going to get infusions every 2 weeks. Is this benefit
sometimes they say that in the zero is better than
Yes.
so many can argue, this is at least stabilized.
So the 44% is related to the treatment. And the treatment of and the 22% is related to the placebo. So these are the adverse effects that appear. There's no crossover. It's a parallel flow. So whatever is mentioned carries so many patients.
But Alzheimer's is not a rare disease, though, like if you're looking at
21% of the patients had a side effect.
how much?
21%.
Yeah, that's in general. Maybe some of the side effects were tolerated and stuff, but some of the side effects are serious. The area was
It's only for area, right? 21.5%. Around 2%. 200 patients out of
How many PET scans do you have in Saudi?
This is the table. So overall, you had almost 88% that had some kind of adversity. And then you can break it down to the other stuff, so the serious ones. So the one that is of concern is the area with microhemorrhage. So that was 14% versus 7%. And for area E, which is with encephalitis, is 12% versus 1%. So there's a high risk for this adverse effect. Maybe, probably those. But then, so again, somebody who's early 60s, still not retired, has a job, might be willing to take this risk and say, over a year and a half, I still want to maintain whatever I have left from my abilities to actually do my work and everything. I have a family, I have children, whatever. Versus somebody maybe who is in nursing, maybe has multiple other comorbidities that are more important. So you see how the value of the drug can be very different from longevity to
psychiatric diseases, street with Alzheimer's.
And anything else?
Unconscious.
Do you think there's also, so there's a health diagnosis, right? To actually diagnose it correctly. Like there's a lot of overlap with other diseases that you might miss, right? So you might be treating the patient with very expensive medication, you need something else. So I think early diagnosis and correct diagnosis.
I believe also we need to measure the cost of side effects.
So someone with area would probably be hospitalized for 2 weeks. Hospital, 50% of patients with percent. So that's a big burden on
Well, thank you, everyone. Well, thank you so much. I would appreciate it. We can actually start having volunteers, whoever is interested, to present whatever they think it's important for us to know about the medication. We will not ask everyone, but whoever is interested, who's ready? You ready? I have here Dr. Amin. Dr. Shahama. MashaAllah. Ahla wa sahlan. We have Dr. Shahama. She's interested now to present her findings from, going over the study. Without further ado, thank you.
Thank you, Doctor. Okay, so we're seeing very interesting study, lecanemab in early Alzheimer patients. First, we look about the what's the intervention and what's the comparator for the study. Lecanemab and the comparator was placebo. So here's the question: is placebo enough to be a comparator for patients with early Alzheimer's disease, or do we need a standard of care? Do we have a standard of care for those patients, cognitive or functional supports?
I think that's an important point. So we always look at the standard of care, what it is, and whether it was equal in both arms. That's the important thing. So it doesn't matter if you did allow standard of care as long as it was equal in both arms, right? So if anyone had behavioral therapy or any extra kind of care out of the normal, you have to make sure that it was equal between two groups, right? Because that's the whole purpose of randomization, is creating those two groups that are equal at baseline. And now that change that you're doing, so the intervention versus placebo, that was what caused the end result, right? So that's an important point. And we discussed that on our table too. So the effect of the environment, other factors that weren't accounted for. Typically, your randomization should deal with that. So the unknown confounders, we call them. So things that are unknown.
I mean the comparator itself. No, now we have early diagnosed patient with Alzheimer. Do they are treated with placebo, or do they have a cognitive support?
So they
They
did
didn't
allow.
mention. They didn't mention anything.
They did allow to continue the standard of care, whether it was Memantine or yeah, they did mention that they were allowed to continue. Yeah, the important thing, but they're not disease-modifying therapies. So this is the first disease-modifying therapy. So it is, I think, logic to compare it to a placebo in this case. Yeah.
Okay.
As a matter of fact, sometimes it's unethical to just put the patient on placebo only. So that's why you have to actually add the standard of care
In both of them, yeah. That's what's usually.
a lot of the trials, they allow the standard of care, and then they add to it either a placebo or
Actually, one of the things that's also, they mentioned that it was being done during COVID-19. So that's one of the things that we can, yeah. So one of the endpoints, which we are not sure that is it a surrogate for, a right surrogate for Alzheimer's disease or not, which is the one they did in the amyloid. Is it a right surrogate for Alzheimer's disease or not? The duration also.
From our previous drug that you mentioned in the introduction.
Yeah. It was shown that.
Still, we don't have an answer if this is a really surrogate marker. It helps though.
And they found that it's not improved cognitive effect. Well, it's a good point that they mentioned, and the one of the main endpoints that the scale they found, they assessed the patients on the cognitive scale. It's validated scale, and which is a good point to mention that patients with Alzheimer's should be assessed individually.
The primary endpoint?
Yeah.
Was it surrogate endpoint?
No, it's a clinical endpoint, so no, it's not.
What do you think, Dr. Mohammed?
I don't think it's a surrogate.
Okay.
This is,
Just a clinical endpoint.
Clinical.
It's purely clinical, patient-reported, right? Yeah.
Patient reported
We've been
outcome.
arguing about patient-reported in Alzheimer's patients.
Yeah.
Or their caregivers.
Or their caregivers.
caregivers,
You
yeah.
said caregiver. Okay, I missed that.
The duration also of the study, it was 18 months. Is it enough for patients with early Alzheimer's or not? We're not sure about this one.
Yeah.
So for
They need continuous monitoring.
so for us, we will wait for more informations, and we're not taking. Yeah, the side effect. That was important. Sorry, I forget about that one. One of the side effects, which is the hemorrhage, it was doubled in the lecanemab arm compared to that one. So that's adding cost for the medication, which is already high cost medication.
It seems high in this, with this drug, because the side effects are really critical needs and patients more intense care.
Yeah. One last thing is the patient preference for such medication. We see that the adverse effects, that's been the hemorrhagical one, and the reaction that's been from the medication, all these things, the edema, is a patient will be preferred to take such an intensive medication or for mild improvement or not?
I think the side effect, the hemorrhage, mild may be temporary and maybe discontinue by discontinuation of the medication, dependent mainly on the dose and duration time. It's a side effect mainly.
Yeah.
Mild hemorrhage.
Can I comment on that? Because this has to do with the efficacy versus effectiveness issue, because sometimes when you have a trial running and you have this very controlled setting where you're monitoring very closely for symptoms like that, is very different in real life when you leave patients, and sometimes you have the same side effect, but the severity is much worse in real life because you don't have that well-controlled setting where you're continuously monitoring patients for these side effects and you have an eye on them. So, so that's one thing to consider also, that if you do have a severe or a very serious adverse effect, the severity and the frequency can be very different in real life. So do you have the means? So that's for an HTA would probably be, do you have the means to follow up on this safety issue or not? Will you be good at that or not? So yeah, excellent. So shall we go with Dr. Mohammed's table? Excellent.
Please. So my team is quite shy. They don't want to present. So they refuse. So they asked me to. Yeah. Okay. So maybe I'll stand on this side so I don't have my back to everyone. Okay, so we looked at a couple of factors. So we looked first at the internal validity of the study. So whether or not the study results can be explained by the intervention or there are any other biases. And there were 4 factors that we took into account when we did that. So we looked at the randomization process. Did they have allocation concealment? Was there double blinding, which is really important for this kind of study since you're measuring patient-related outcomes or patient-reported outcomes. It's really critical to avoid any type of bias. And also if they have intention to treat analysis, meaning how do they account for those patients who did not complete the study. So based on that, we came to the conclusion that this study had good internal validity. That doesn't necessarily mean that it has good external validity. That's another factor that you need to consider, whether you can try and generalize the result that you have to the patient population. So some of the limitations that we identified during our discussions was, first of all, the patient population, which was early Alzheimer's. How common is it to diagnose Alzheimer's early, right? So as an internal medicine clinical pharmacist, especially in geriatrics, a lot of the times the diagnosis is late. So the patient presents to you with moderate to severe Alzheimer's. So how common is it in our setting to diagnose Alzheimer's this early? The other question or limitations that we had concerns about was the outcomes themselves was validated for clinical trials. The question is, are those outcomes validated or can they be done in clinical practice? Because obviously it would seem that this is a score that needs to be done for these patients to assess the cognition and function and so on and so forth. Can that be replicated in clinical practice? Yeah, yeah. So, and that takes me to my second point, my other point, which is resources that need to be allocated for this treatment. So it's not just the cost of the treatment, it's things like PET scans that they used. Also, you need infusion centers, obviously, right? So this is not a home treatment. This is patients have to come to an infusion center or at least healthcare setting. Do you have them adequately set up in your locality to be able to do this? This was mentioned already about the follow-up, 18 months only. So that means that you might not be able to capture the full effect of this drug on a long-term disease, both in terms of its effectiveness and also in terms of its safety. So there could be some safety signals that are missed out as a result of the follow-up. And then another aspect that we had concerned about was the magnitude of the results themselves. So when you look at the outcomes that they looked at, the difference was 0.45 in terms of the score between the two groups. Is this clinically meaningful? It was statistically significant, yes, but is it clinically significant or not, which is, I think, another factor that you have to take into account. What is the another factor that we wanted to understand, a potential limitation, is obviously Alzheimer's is a condition, is a disease that doesn't just affect the patient, but it also affects the caregiver. So did they, at least I couldn't see it, but there was no capture of what impact this drug has, not just on the patient, but on the caregiver? Does it reduce the burden on the caregiver as well, or not? We also had a concern about obviously Alzheimer's, like any sort of chronic disease or any type of disease, has its own complications outside of the disease itself. So falls, decrease in nutritional requirements, and so on and so forth. Does this drug have any impact on those in terms of those complications that are often result in significant indirect cost implications for your center or for your country or for your hospital or whatever it may be? So these are the limitations and factors that we identify. Thank you.
I'll let Dr. Amal go first, and then maybe we can go back to my table.
I would like to echo Dr. Muhammad Ahmed. Nice word related to the medication. However, we are all agreed that we need more data regarding this medication, and 18 months was not enough to assess this medication, and also the early diagnosis of Alzheimer's. We cannot justify this medication controlling the disease on the long term or not. That's why we need like 5 years assessment for this medication.
Excellent.
And we do it in Voco.
Yeah.
Thank you.
Thank you.
Starting the age of 50 and early diagnosis of Alzheimer's. And the other one is who did the interview, because they didn't mention in the methods who did the interview. And yeah.
The blindness itself, it wasn't mentioned. It's intravenous medication. So the placebo, how did they blind the patient? Did they give them any injection for whatever?
I think it's in the supplement, maybe the details.
In the supplement.
Most of the new studies now, they don't really give a placebo. They compare to the best supportive care or other care that is given for the disease instead of placebo. This should not be done in a placebo. And it has a lot of ethical concern. Median age of 70, you inject them for every 2 weeks. You ask them to enroll in the trial that you inject, it could be a placebo for every 2 weeks for life. It just, I don't think it's very applicable and it's ethical to do.
Yeah, but since they already mentioned the double blind, they have to mention what is the blinding process. Also, the intention to treat, they mentioned modified intention to treat analysis, and I don't know what is the meaning of modified, since they already mentioned that almost 20% of the patients on the treatment are drops, and 15% of the placebo patients drop from the analysis from the population. So I wonder if this modified means that they only included the patient who remain, which is per protocol, mask per protocol, or what is the meaning of modified intention to treat?
The duration also.
Duration of 18 months. Also the meaningful point of, we read about the meaningful point is two meanings that decline, meaningful decline, and the three change in the memory. However, the change is only point something. So even the first phase 2 trial, they showed 2 point something change in the phase 2 trial. So as this trial, it's only statistical significance, not clinical significance. And
I also just want to add a point to reiterate to what Dr. Ghada mentioned about the age. It's okay that they included patients in the age of 50 and above. Acceptable. I don't have a problem with that. However, they should have actually told us, how many patients are listed as 65, like between the age of 50 and 65, and how many are actually above that 65. And then not only the characteristics, but also they should, when it comes to the analysis, they have to do subgroup analysis, is it actually different? Because maybe if I'm 50, probably I would be responding to the medication even better, they're given my organs, function, and everything. So they should have mentioned or do a subgroup analysis to differentiate between those between 50 and 65 and 65 and above. That will make a more sense of the thing.
I have one last point, that they included patient up to 90, age of 90. So those patients has a lot of comorbidities. Maybe a lot of them have a stroke or something. They didn't mention anything regarding the previous history of the patient and also the previous family history of Alzheimer's disease.
Yeah. So I think our table pretty much sums up most of what was said by other tables. Some of you don't know this, but I worked with Dr. Muhammad Ahmed for almost a year, so we kind of think alike. I owe him a lot for learning a lot of things that I know at this point. Just want to show gratitude. So we did discuss the age similar to your table, so that maybe the value of this drug for someone who is early diagnosed, still active, has a good life, maybe still young, working, not retired, and really values that he continues for the next coming years in the same functionality, versus someone maybe with comorbidities and more serious diseases at like an older age, and maybe the value for him is different than someone that has to go every 2 weeks to the hospital, and so maybe they value being at home with their grandchildren or whatever. So I think one of the main limitations, they didn't really focus a lot on what comorbidities the patients had and how they dealt with that. The COVID issue was also brought up. The fact that it's a very subjective tool, even though you do get a score at the end, so it does seem like it's objective, but it's not. So it is something that is where you collect the data by interviewing patients or their caregivers, so there can be a lot of variability in how the data was collected. And then when you look at that compared to the magnitude of the benefits, so that minus 0.46%, then it matters, right, how you collected the data. If the benefit was big, like something like 6 points on an 18 scale, you wouldn't be really worried about the noise of like how you collected the data. But when you have a subjective tool like this and the magnitude is so small, you don't really know at that point. Yes, statistics can help you kind of rule out that it's not by chance, but there's still a lot of uncertainty, so I think that's something. And then again, like Dr. Mohammed mentioned, so if we don't use this scoring tool, which was developed for clinical trials, we don't use it in practice, it's likely that if we do adopt this technology and add it to the formulary and use it in patients, we will be unable to really in real world look at the effectiveness of this drug. So really following up on those patients, are they getting the value we want from this medication at the end, would be probably hard. Long-term efficacy, so what happens after the 18 months? So will they continue to see that kind of stabilization and progression, or will it suddenly drop? So we can assume that this is an exponential benefit, but it's probably not, what we know about the disease and how the drug works. We talked about the genetic background and environmental background, how that can affect the outcomes in these diseases, and that can be very different from the patients included in this trial versus patients in our setting. So the cost of adverse drug reactions, so that serious adverse drug reaction, is that something patients are going to be well informed about? Are they going to, what's the frequency of that? How are we going to deal with that? I spoke a little bit about that. The prevalence and incidence, so what number of patients are we talking about, and more data that we would need about cost effectiveness. So this drug costs around $120,000 per patient, but we don't know how many patients might be eligible for this. So it could be 500, but it could be 7, right? So it depends on who are you gonna include, right? I think that's mostly our table. Any other thoughts you want to add? Yeah, most of it. I think we have agreed. Yeah, so maybe a subgroup. Yeah, and a budget. Yeah.
Especially the wide age range that we don't know again about mortality and so
Dr. Cliff, do you have any additional thoughts? Maybe something we didn't think about?
You thought about a lot.
A lot.
What occurred to me was, as I'm listening to this, I'm thinking, wouldn't it be great if every HTA could have such a so actually, we all look at the study, we're in the same room together, we discuss it together.
Yeah.
Wouldn't that be great?
That would be great.
But I hope we can learn from this. Just a few other thoughts, and it was just wonderful to hear how people picked up some very subtle and important points here. The whole thing about standard of care was very important, and you have to look carefully. What was the standard of care? How was it applied? Did both groups get it the same way? Okay. Now, in Alzheimer's, we know that there are these other drugs, diazepam and a few others, that have been approved earlier. They're not, we say, disease modifying, but they're symptom modifying temporarily.
Yeah.
So was a diazepam or similar drug part of the standard of care or not? If it was, does it complicate the effect? Is there interaction? You know, a lot of questions. But the standard of care thing is really important. Another important thing is that, in contrast to the study that I shared earlier, which is only about a biomarker that they thought was a surrogate, in this case you had the scoring tools, which really were about function, okay, cognition, memory, judgment, which is what patients and their caregivers experience. So the combination of the amyloid plaque reduction, which is indicative, helpful, but not everything you want to know, that was good here. Good point about the safety and adverse events in particular. 18 months does sound pretty good, but there are two kinds of adverse events that might be missed in a clinical trial, even if it's 18 months. Number one, rare adverse events. A clinical trial may not be large enough to pick up rare events, and a clinical trial may not be long enough to pick up delayed adverse events. So it's the rare adverse events and delayed. So you might put this on your formulary, which might say, listen, we want to have longer term follow-up data as well. The technical aspect here, and I'm not an expert in this, but people that do tool validation might say about these tools, like the one that was 6 dimensions times 1, 2, 3. They just added them together as if they were equivalent. So are all 6 dimensions of equal importance? And is a 1 and a 2 and a 3 the same for each one of those? So they kind of just threw them together and added them up. Maybe that's good enough, maybe not. So that's a fair question to ask. And related to that is, it looks like a pretty good tool, but you always say, is there literature showing that this tool has been validated in this patient population? And maybe it has, but it's a fair question to ask every time. 2 more points. One is that you picked up on the 50 to 90 thing. Age range, it is often the case, not this case, but payers will often say, oh, I'm so glad that you proved that this thing works in age 50 to 65. Fine, we'll pay for those people. We're not going to pay for older people because you didn't show us a clinical trial. So that's always a payer can always say, hey, I have an idea from my hip pocket saying, sure, I'll pay for these guys, but not these guys. You know, so that's an important consideration. And then the last one has to do with, even from an HTA standpoint, can you please supply me with information that I can share with patients and their caregivers to make the difficult choices? Remember the cancer example I gave, this drug, some higher side effects, lower side effects, longer duration, so there may not be a right answer for all patients, but patients and their caregivers will want to know, what are my probabilities here either way to help me make an informed choice with my physician? And so HTA might ask for that information. Some of it can be extracted from this stuff, but you might also want additional information to inform shared decision making. So those are some things I was thinking, but gosh, you picked up all great stuff. That's good.
Okay, so we'll take a short break for Salah. And then we'll come back. We have our symposium. Dr. Ahmed Jaziri will be presenting a 20-minute talk on that. Thank you, everyone. I hope you enjoyed this session.